Thank you, everyone, so much for joining us. My name is Casey Minnis. I'm the Director of Communications for the Multiple Sclerosis Foundation. I'm happy to be here with you today and excited to be addressing this important topic of advocacy for yourself, your family, or your significant other with MS. Today's topic will be presented by Dr. Adam Chaifetz. Dr. Chaifetz is a board-certified chiropractic neurologist. Since 2008, he's been the program coordinator for the Comprehensive Multiple Sclerosis Center in the Department of Neurology at the Jacksonville campus of the University of Florida. He manages the program through the interaction with patients, providers, and staff. He's a strong advocate for patients and interacts with governmental relations representatives and local and federal legislature. Dr. Chaifetz has been in clinical practice since 1987, and his expertise has always been in a collaborative medical environment. We're very excited to have him here today to talk about this important topic. Dr. Chaifetz has offered that if anyone has questions, you can ask them during the presentation, but we ask when you're not speaking, please do put yourself on mute to limit the amount of background noise and interruption during the presentation. We'll also be able to take a few questions at the end of the presentation, so if you feel like holding your questions till the end, that's fine too. So with no further ado, I turn it over to Dr. Adam Chaifetz.
Thank you, Casey, and thank you everyone for joining us today. I appreciate everybody's patience. As you can probably tell, this is my first hosted Zoom conference. I've been in on some, but usually invited. And for those of you that saw Dr. Adrian DeBerry's a couple weeks ago, this will be a helpful continuation of some of the things that actually she covered in her really great lecture a couple weeks ago. So Casey and I actually have done this lecture before, and it was in Cincinnati, Ohio last year, and it was during MS Awareness Month, and they asked me to think of a subject that would be impactful for not only MS patients, but their caregivers and their families. So these are some of the most important things that I've seen in the past 12 years being the program coordinator here. Some of the challenges that happen in an MS practice are a lot of times behind the scenes, and the providers play a role in helping us, but they don't have direct roles in certain things. And that's where some of the administrative staff comes in to help make a fortified team of people that know how to work processes efficiently to get things for patients in an efficient manner. But we're going to use some analogies as I go through this, and I want you all to think about healthcare as a business, as well as you being the consumer in that business. So just like when you go into a restaurant or, God forbid, a car dealership, you know that you have certain rights. And we're going to talk about some of those rights and privileges that you have as a patient as we go through this. Now, the great thing is that I can see some of our participants, and I actually know some. So we do have some MS patients that might be able to chime in and tell us exactly what their experiences are as we go through this. So my belief is always that personal knowledge of certain things really is invaluable, especially when it comes to the multiple sclerosis realm. And when a person's diagnosed, there are so many questions that go through their mind. And many of those questions can be left unanswered, because an office visit with a provider can only last so long. And so a provider cannot spend an eternity explaining all the idiosyncrasies of a condition, the diagnosis, the treatment, the symptoms, what you can expect, how to get resources. It's almost impossible. So the team that they assemble to help patients is really important. And that's what differentiates an MS center and MS specialty practice from possibly a general neurology practice. And so Casey, I don't know if you remember, but when I first talked to the patients, my analogy was, remember we used a car analogy. I said, so if you were a Ferrari or a Rolls Royce, you wouldn't bring your car just anywhere.
Right.
Right. And so I want MS patients to think that they are the Rolls Royce or they are the Ferrari. And that's why they require a higher level of expertise in order to manage their condition. So knowledge of some of these processes helps patients a lot. So one of the things we're going to talk about, these are real life things that we've experienced in our practice. And these are real life things that I can assure you have happened. All right. So we have to start out with the basics when it comes to an MS presentation, because we know that either at this time or in the future, those that are going to be viewing this presentation may be brand new, diagnosed with MS, and they have questions about their diagnosis. So I'll just go over this very briefly for those patients that have had MS for a while. Please bear with me. So the most common form of MS is the relapsing form. And if you see abbreviations, it's RRMS. And approximately 8 to 9 patients out of 10 are going to have this type of MS. It's generally characterized by periods of relapse along with periods of remission. And when I started in the practice of MS care, relapses were a lot more common because the medications at the time were limited and were not as effective as the current medications that we have now. So when we talk about relapsing, remitting patients, in the general practice of today's MS center, our goal is to see minimal, if any, relapses in a patient that has this diagnosis if they're on the appropriate medication and the appropriate regimen. Now, the second type of MS that I'd like to talk about is primary progressive MS, or abbreviated as PPMS. And until very shortly, recently, this type of MS really did not have any straightforward treatment paradigm. Now, that's not to say that providers in the past, especially a decade ago, that they wouldn't try to treat patients that looked like they had progressive qualities, because I think the thinking at that time was that they wanted to do anything and everything to stop the progression of what we see in patients that present with primary progressive MS. So how do these patients differ from relapsing? Well, they don't have periods of relapses. So they don't have what we as neurologists would call a clinical event. So what's a clinical event? A patient that's had a relapse usually will have an event like a visual event, or they'll have weakness, or they'll have numbness, or they'll experience something that is very distinctive as being what we call a neurological episode or relapse. Now, primary progressive patients don't display that type of history. Instead, what you see is a slow progression of usually loss of mobility, possibly loss of other functions, but you do not see a distinctive clinical history of neurological episodes. The secondary progressive multiple sclerosis, many years ago when we only had 4 or 5 disease-modifying agents, if a patient were completely untreated, being diagnosed with relapsing MS, it would take a period of approximately 15 years before they would hit a stage at what we would call secondary progressive MS. Now, this would be characterized by a slowing down in the number of relapses, along with an increase in immobility. So we would start to see patients whose gait or balance would be starting to decline, needing assistive devices, and maybe having some other problems depending on where the lesions are in the brain or in the spinal cord. Now, the rarest form of MS that there is a progressive relapsing form of MS, and probably if it's diagnosed at all, it is a very, very low percentage of MS patients. So we really do not see an FDA approved treatment for it. So because of the low incidence of this condition, my assumption is it may be treated as a primary progressive, or it may not be treated at all. It really depends on the experience of the clinician. Now, as an MS patient, one of the things that is so important to know and understand, and we're going to make the assumption here that you're an MS patient that has been prescribed a disease-modifying medication or a drug for your treatment. Now, this would not include necessarily infusion therapy, because that can be covered sometimes in a little bit different way. So if you are on a disease-modifying medication and you receive shipment of it every month through the mail, it's important to know and understand basically how you get your medication and where it comes from. Now, this sounds simple, but you wouldn't believe the questions that we get all the time from patients when they need renewals of their medication, and they're not really familiar where their meds are coming from. So we're going to talk about some sources of how are patients getting their drugs. The first thing you need to know and understand is your insurance fully covering your medication, or are you on actually a type of assistance program? Why is that important? Well, our pharmacist can tell you it's super important, because if you're on a free medication program from the company, that drug might come from a different pharmacy than your insurance that may cover your medication. So as you can see, it becomes pretty complicated from behind the scenes. And if you ask your provider will say, ask Dr. DeBerry or Dr. Chaifetz, because they won't know. So we'll talk about foundation funding. What is foundation funding? And then some patients may be surprised to know that they're getting their medications 100% for free from the company. And if that's the case, we're looking at medications that could cost sometimes as much as a house. So how does foundation funding occur? Where do foundations get money? When patients have certain types of insurance plans, and specifically the patients who usually fall into the foundation funding caveat are usually governmentally funded patients like Medicare patients. Now, when a person goes through choosing their insurance, they have to be very careful in choosing the plan so that they don't get caught up in a plan that A, doesn't cover their drug, or B, has a copayment that's so high that it's just not attainable for the person to afford it. This is where foundation funding comes in. So here's what happens. A company makes a drug, but they cannot give a patient directly so much money per month as a copayment assistance if you have Medicare, if you have Medicaid, or if you have TRICARE. These are government plans. So instead, what happens is the company will fund a foundation, and some of these foundations would be the Chronic Disease Fund, NORD, the National Organization for Rare Disease, HealthWell Foundation, and then the Patient Assistance Network will give you an idea of numerous available funding sources. Now, here's the bad thing, is foundation funding is not guaranteed. So it's frustrating for patients that get bounced back and forth between periods where funding's not available. Why is that crucial? It's crucial because if a patient doesn't have funding, they don't have drug. And if they're not on drug, that's serious. It can cause relapses, disruption in care, and all kinds of things that these genius insurance companies don't think about. So please understand, number one, if you have foundation funding, who's the foundation? What's their number? Who do I contact? Okay, very important. Now, patient assistance programs through a pharmaceutical company. So certain insurances. So I work at UF Health, and I'm really lucky because if I were having to use my insurance, I would be offered copay assistance for a drug for almost any condition that's out there because of the classification of our insurance. So we see all the time patients that have very minimal co-payments because the company does allow some financial assistance to be offered through the government. So for instance, if you have a job, a regular job, and you and your spouse are covered or your family's covered, most likely the company who makes your medication is going to give you copay assistance for that medication. It behooves you to take advantage of it. It behooves the company for you to stay on it. And here's the important thing for y'all to understand is that you have to ask for it. So when we send in the start form and send all the information to the company, It's up to the patient to say, hey, I need to understand how I'm going to afford this medication. And that's when they say, okay, Ms. Jones, I'm glad you asked. Because you're eligible, we can offer you copay assistance. So patients, please understand, this is also done on a yearly basis. So when it comes to December 31st, please make sure that all of your enrollment in your plans is going to be timely for the next year. All right? So another really good thing to know, and for those MS patients that are out there, if you have a notepad to jot this down, this is important, okay? So know where you get your medicine from. What pharmacy does it come from? Because when a patient has a certain insurance, believe it or not, insurance companies are buying pharmacies and pharmacies are buying insurance companies. So certain insurance companies mandate that drugs come from a certain pharmacy. Now we're lucky because some of our patients are able to be serviced through our own specialty pharmacy that we established here at UF Health with the help of Dr. DeBerry and the pharmacy staff here. They've worked hard over the past 5 years to try to make it so we can get the medications for our patients and help them get their medications in a timely manner. So know where you get your medications. Important to know how long your authorization's for. Okay, just to give you a tip, the more expensive the medication, the less the length of the time of the authorization. So if you have a super expensive medication, they're not going to give you an endless authorization. Many of the infusion therapies may only be authorized. We've seen them monthly where we've had to get authorizations. And then it's not uncommon to see 3-6 month intervals. If you see 1 year intervals, they're being decent. Okay, so know the start and end of your authorization period. Why is that important? Well, because if you don't know when your authorization start and ends, you're not going to know if your prescription that your provider's written is any good. Because if they've written a prescription but you don't have an authorization, you're not going to get your medicine. Tell you about another circumstance you need to understand before you receive delivery of your medications. Please contact the company and establish your copay arrangement. You do not want to sign for medications and end up with a $9,000 bill. Okay, once you sign for those medicines, they are yours. They're not returnable. Okay, so please, those patients that are new to this, understand from your pharmacy and from your insurance company exactly what your obligations are prior to doing this. And then real important, we've had patients calling them out of medicine. Okay, well, we don't have your new insurance, so how could we possibly get your new medicine? So if you do have a change in insurances, please call our staff and let us know so that we can do our best with your new insurance to get your treatment, your medication, whatever you require covered. All right, so many patients don't know and understand the actual cost of these medications. And so if we analyze the products out there, and this is not current, this is from a year ago, so my brain tells me that prices may have actually gone up instead of down. And so it kind of gives you an idea of what the cost of these medicines are. So for instance, if we go down the list, if you look at Avonex, you're getting 4 injectable pens for $7,000. Okay, so if one's damaged or your dog eats it or something, I want you to think about the cost of that. So as we go down the list, you can see the average cost of these medicines is around $7,000 a month. Now, these are injectable and oral medicines, okay? The infusible medicines are in a whole different league, okay? It's a whole different ballgame, all right? So what if on January 1st, you get a letter that says the drug you've been on for eternity is not going to be covered anymore? And you need to take X, Y, and Z as a substitute, and you need to talk to your doctor about it. If anybody's ever experienced this, I can only tell you that it's probably one of the biggest headaches when it comes to MS management behind the scenes. And the reason is because insurance companies are able to negotiate pricing of these products. And at last count, there are over 14 drugs available now for MS. Now, if we go backwards here for a second, if you were paying the bill, which one would you choose? I'm thinking probably this one here. Okay, I'm thinking probably the $1,400 a month one. Okay, if you had to pay the bill, right? So insurance companies look at it from a strictly fiscal thing. And any patient who's ever tried a generic drug can tell you that it can go seamless, like there's no problem, or there are patients that do have true reactions to the generic formulation. Now, MS is funny because up until just a couple years ago, there were no generic equivalents. So we really didn't have to worry about generic drugs in the MS realm. So what the heck do you do if you're on a drug and your insurance company sends you a letter and sends you're getting a 30-day supply, and after that, you're done. You're on your own. And then I love the fine print. The fine print always says, this doesn't mean we're not saying you and your doctor don't agree that it's good for you. We're just saying we're not going to pay for it. You're welcome to pay out of pocket for it. And so I know most people would not choose that option. So in our office, if we see this happening and a patient alerts us, what we do is we do what's called a formulary exception, which means that the provider has to demonstrate in their notes the patient's been on this drug, clinically stable, and then we do an exception to their formulary asking for a medication that's not listed on their formulary. Now, some of the insurances are very tough on this, and some of them will automatically deny a medication if there's a generic available. Okay, so at this point, what we're looking at is only really one drug that is a generic at this time. But what is a formulary? So a formulary, and let's take Blue Cross or United Healthcare. They choose a list of drugs out of the 13 which are available for your prescriber to prescribe. And it doesn't necessarily mean that it's the one that your provider has chosen. So again, it's a real easy situation. If your provider picks a formulary drug, then you'll have no problem getting it approved through the insurance. Now, when we look at generic versus brand, okay, the only medication that falls into this category is what used to be called brand Copaxone. So Copaxone is now glutatamic acetate. And patients were calling us adamantly rejecting their insurances, forcing them onto the generic. Now, we have tried to get these approved through appeals and through formulary exceptions. But I will tell you that some of the insurance plans are so steadfast in their denials that they make it almost impossible for a patient to get a brand Copaxone unless they have literally tried and failed the generic and it's been documented. So when an insurance company sends Mrs. Jones a letter that says, you've been on Copaxone since, well, it's been out since 1996, so let's say 2000. You've been on Copaxone for 20 years, and we now want you to take the generic, okay? So most patients in my mind that have been on something for that long a time and it's been working for them are going to be very anxious about changing, and I would not blame them. And here's what the insurance company doesn't think about, okay? They do not orchestrate the switch from the brand of Copaxone to the generic of whatever's chosen as an alternative. And anybody who's ever started a new MS drug knows that that requires a new start form. In the case of an injectable medicine, you have to coordinate getting the device, coordinate the nurse injections. The patient loses their financial assistance with the brand company. They have to develop a new co-payment source, and then they're going to get kicked around from foundation to foundation. So just to give you an idea, the $1,500 or $1,400 generic drug will cost a Medicare patient $500 to $800 a month if they do not have foundation funding. We have found that out from the generic companies. They do not offer free medications. Now, looking at this trend, it's been my experience over the past 10 years that this situation is not going to get better. And it's actually getting worse because we're seeing this in now to where the insurance companies are starting to try to manage patients clinically and get them out of one setting and into another setting. And what I'm talking about specifically is infusion therapy. It's going to get worse. When insurance companies are in control, like how many people would cite Blue Cross and Blue Shield as the purveyor of their health? I mean, I don't know about you, but I trust Dr. Silliman. I trust Dr. Katsafanis. I trust Mr. Davidson's neurologist. I trust anybody other than an insurance company to make a determination about my healthcare, your healthcare, anybody's healthcare. So think about it. When you get that letter in the mail that says, okay, your Copaxone or your whatever you've been on for 10 years isn't covered anymore. We want you on X. And then you do your Google search and you realize that the drug they want you on was used 10 years ago to treat patients. And so who wants a drug that has an efficacy that is much lower than what the newer medications can offer? Would anybody raise their hand and say, hi, I want a less effective drug? That would be me. I don't want my condition to get better. No, of course we would. So understand that as the patient, you're going to have to do a little bit of fighting to work against the forces that only look at your condition as a fiscal thing. Okay? There are usually big ramifications that occur when a transition from brand to generic comes. I think mentally a patient doesn't like it, so there's an increase in adverse events because I think they're anxious about it. Number two, the formulations are definitely not the same because they're made from different companies. And then lastly, we went over the steps that everybody's been through if you've been on an injectable drug. The companies don't pre-plan that, and most offices may not have a dedicated person that's able to finesse the process the way that it's supposed to be done. All right, so what companies are doing this? Well, United Healthcare. So United Healthcare has cornered the market in the Medicare realm. How do you know? Because if you look on TV, they're endorsed by AARP. And what that means, folks, is that if you have Medicare and then you have United Healthcare as your Part D Medicare plan, what it means is that your co-payment for your drug can be anywhere from 25 to 33% of your drug. Okay, so I want you to think about that. Drugs that are $8,000, what's a 25% cost of that? It's roughly $2,000, $1,500, $2,000. So most patients are not going to really be on board with that. Okay, Blue Cross and Blue Shield, they also are not covering the brand of glatiramer acetate, and they're being really hard-nosed about it too. Now, anybody that's ever dealt with TRICARE knows that you're dealing with government. So one of the caveats is when a new drug is announced and a new drug is FDA approved, folks, that doesn't mean it's available, okay? Because it's only available if it's put on formulary. So like with the government, if your drug's not on a formulary, you literally might need an act of Congress to get it approved, okay? Because if it's not on the formulary, they don't even give you a way to try to get it because it's not on the formulary. It's kind of a crazy system, okay? And then Medicaid, as far as the state of Florida, our experience has been that they are definitely utilizing the generic version of the glatiramer acetate when they can. We are having impossible times getting the brand approved for a patient. So what does that mean? It means that if a patient tries and fails the generic, we still try to appeal it, but some of them have been really tough. And that might, unfortunately, facilitate a medication change for a patient. So here's a prescription checklist. And if anybody saw Dr. DeBerry's presentation a couple weeks ago, This falls in line with some of the things that she was talking about. So know which insurances cover what medication. Now, if a patient has straight Medicare, let's say they were awarded disability and then they had their 2-year waiting period and they finally got Medicare, they have to purchase a secondary plan to cover their medications because medications are not covered by Medicare. Now, there are now what are called Medicare Advantage plans, and those are the plans that are all-encompassing plans that cover things like dental, vision, prescriptions. But be very cautious because, like in all other aspects of life, if it sounds too good, it really is. These plans are going to have very high co-pays for the specialty drugs that MS patients are on. So this is where the knowledge of what we've already talked about, foundation funding, drug assistance, and dealing with the companies is so important as you go through this process. Okay? So we want to know if your insurance covers the drug. We want to know where your drug comes from. And then you also want to know where you're getting your funding from. So that should be super important. Just like you have your list of emergency phone numbers, maybe your list of passwords for all your websites that you have to go through, you need to have your MS important list, which has your medication, your pharmacy, the pharmacy's number, and the authorization period, how long your drug is good for. Okay, now, one of the things patients never think about is accessing their own medical records. So one of the things that you can do, and this has become a lot easier since the advent of electronic medical records, like we use what's called the EPIC system, and that allows us to communicate with patients through a system called MyChart. Now, MyChart allows patients to actually print sometimes the actual clinical notes from their visit. Now, if you don't have that capability, you can go and sign a medical release and you can get copies of your medical records every year. And I would absolutely recommend patients have copies of their MRIs on discs when you go to get them copied for your provider. Make sure you have a copy for yourself. And that way you can keep up with all of your imaging as well as medical records, lab reports, MRI reports, because patients move, patients relocate practices, and it's a good idea to have your record for a lot of reasons. Okay? Now, when you go into your provider, most providers do not have an unlimited amount of time to spend with you. Because you have to maximize your time, the best thing to do is to write down a list of just maybe 3 things that you want to cover with your provider. In the age of telemedicine, we're now starting to do a lot more visits through telephone and through distance. And so this may be possible to be covered not in person. It's also important to bring a spouse or a family member to the visit if you're having issues understanding what's going on or just have another perspective. Okay, this question's been asked to me a bunch of times, and patients a lot of times can be influenced by a lot of different things. And so, like in the world of coronavirus, we don't know what the perfect treatment is. Well, with MS, it's a very individual thing. So one patient after another, when oral medications came out, we would hear patients really, really pushing their providers to switch treatment. And a lot of them were puzzled, some not so happy, because to be honest with you, 10 years ago, some people had to inject daily. The ones who didn't inject daily injected every other day and got flu-like symptoms darn near every day. So I can't say I blame a single person for wanting to switch treatment modalities. So when we look at why Miss Jones may have been switched to the pill and why Mr. Smith might stay on an injection, it has everything to do with their condition and the clinical stability of it. So a provider, most of the time, is going to listen to their patient's request. However, it really is not prudent to change something that's been working for a person for a long time. So when we get back into the swing of things and we can actually go to events again, and we can go to promotional events, which again, when we talk about promotional events, we're talking about events that are put on by companies to promote their product. So understand they are promotional, they are educational to a sense, but we don't change a person because they went to an event and liked the presentation. Okay, how do we know a person needs to be changed? Well, we have to have clinical evidence of that. Okay, so how does a MS specialist rate the stability of an MS patient? There are three things we look at in the overall picture. Okay, the first thing is, are they having relapses? Okay, so if a person's having clinical relapses every year, that's not stability. Okay, is a person getting worse physically or otherwise on a certain therapy? Okay, and then the third thing is, are they developing evidence on MRI of the development of new lesions? Because as we all know, lesions can be silent, meaning they don't have clinical manifestations, but we see them developing on our MRIs. Disability is a pretty easy one to gauge, okay? And anybody that's had a relapse can tell you they know when they're in a relapse mode. We're going to talk about a concept in MS care that is at the epitome, at the highest level of MS management, and it's a concept called NEDA. NEDA refers to no evidence of disease activity. So if we were going to have a correlation in the oncology world, we would call this a remission. Okay, so I want you to think about the fact that up until oral drugs and infusion drugs were put onto the scene, every MS patient had clinical or radiographic evidence of some progression, even though they were doing their injections as they were prescribed. Patients developed from relapsing into secondary over a period of time, sometimes a prolonged period of time, but it usually did develop. So the concept of NEDA started actually with infusion medications back in about 2005. And what this concept is this is a medication that is so powerful that it literally halts or stops the process as we know it of active or inflammatory MS. So what are those milestones? Well, we're looking for, again, no evidence of disease of progression on MRI. So we re-scan the person. We look at relapse activity. Okay, we've had patients on some medications for a decade that have never had a relapse. That's pretty darn good. And then the other measure is going to be disability. Okay, so disability sometimes, especially if the person's in the progressive realm, is not avoidable. So how is NEDA achieved? It's achieved through the advent of more effective treatments. So as we know it through clinical research, oral agents are more effective than the injectable ones. Infusion medications are going to be at the top tier or the highest level of the spectrum when it comes to the treatment of MS. And then oral medications also have a very moderate to high level of effectiveness in patients that have moderate to aggressive MS. Now, the problem is that many years ago, when we only had, what was called the CARB, C-A-R-B regimen, that was Copaxone, Avonex, Rebif, and Betaseron, we knew that they weren't going to be totally effective, but we also knew that patients weren't dying on those drugs. Okay, we didn't have patients dying of injectable drugs for MS. Well, that landscape, unfortunately, has changed because with the advent of these medications where we've seen superior efficacy in relationship to injectable drugs, we have a markedly different risk profile with these drugs. So what does that mean? It means that when a patient is moved to a higher level drug, there are considerations of the benefit of the drug versus the risk of the medication. This is a conversation a patient should have with not only their provider, with their family, and then also with a clinical pharmacist who is knowledgeable about disease-modifying therapies. So how do you know you need a new treatment? Not because you had a great dinner and the presentation was good, but look at it like this. Look at it from a clinical standpoint. If you're experiencing numerous relapses, now these have to be authentically true relapses. Some patients may be new to the diagnosis and feel like, a lousy day is a relapse. So it's important to understand what a relapse is. It's an event that lasts 24 hours or more. It's usually a significant neurological event. So for instance, if a person has a temperature from an infection, it can mimic a relapse. Once it gets better, the symptoms will abate, okay? But if a person's had a true relapse, they wake up and they have visual disturbance. They wake up, they have weakness on one side of the body. They wake up, they have numbness on one side of the body or in different areas of their body or face. It's important to report this kind of stuff to your provider. Now, patients know if their disability is progressing. This is another reason why bringing somebody like a spouse or a caregiver or a friend to an appointment is important, because people who are married will tell you that spouses can be important forms of information telling you, the truth about what's really going on behind the scenes. The patient may not be using an assistive device because they don't realize the wall is what they're using. Okay? And so injections in particular can cause some really bad injection site reactions, especially when they were doing them on a daily basis. And then some of the medications, some of the oral medications have some side effects that unfortunately to some patients are intolerable. So for those, that are wanting to go back to doing daily injections, or any injection for that matter, please understand that that's always an option. And it's also a situation to where, compared to the risks of some of the more effective drugs, we still have quite a few patients on platform drugs. So that should tell you that there is no one drug for this condition, that this drug is treated individually, and it depends on you as a patient, how you respond to things, and also the decisions between you and your providers. All right, let's look at disability. Probably one of the most discouraging things that we see from behind the scenes in an MS practice is when you have a very young person, or a person who's capable, who has a diagnosis given to them, and to anybody that's rendered a diagnosis of MS, and I've been present many times over the past decade to where patients have been given the diagnosis, and I can tell you it can be a tough pill to swallow for some folks. And in their mind, they don't know and understand what their future might be. So sometimes we see patients who automatically think that their life is going to be curtailed, or that their life is going to change dramatically. And when we look at the way that MS was treated a decade ago, or 12 years ago when I started, versus right now, I can tell you the tools that we have available are much better. So we're able to treat patients in a much better fashion, in addition to the fact that that patients who are diagnosed earlier have a better outcome if they're managed earlier. So disability is not a given situation. Just because a person has MS, they're not disabled automatically. So I want patients and those out there to understand that it's a process. If a person is going to be going through the disability process, I want you to think about a storybook. And the person who's going to be reading your story is going to be a Social Security judge. So in order for patients to qualify for disability, there are certain things that have to be present. So for those patients that are interested in understanding, go to the website, the government website for disability, and they will list some of the things that are necessary for the consideration of disability with multiple sclerosis. So some examples are, if a person's had a visual attack and their vision didn't recover, then they can be blind. Unfortunately, not all patients that have relapses recover. So it's not uncommon that a patient, their mobility changes after a serious relapse, okay? And so understanding the criteria for multiple sclerosis disability is important in the process. Now, qualifying for disability is also important to understand. So if you're 21 years old and you're diagnosed with multiple sclerosis and you think that you're disabled, your options are going to be not plentiful, okay? And the reason I say that is because most people who qualify for Social Security disability income have to have worked and paid into the system for a period of about 10 years, okay? And so what that means is that they go through the Social Security system. The judge says, yes, Miss Jones, we see that you stopped work 6 months ago because you lost vision in your left eye due to a relapse, and now you're having weakness in your right leg. Well, you meet the criteria. This is what's going to happen. You will have Medicaid probably for 2 years, and then after that time, you'll be awarded Medicare, okay? And then depending on what your job was, what your salary was, and how much you've contributed into the system, this is what your disability award would consist of. So we always tell patients to stay in the system as long as possible because it will maximize your benefits, okay? Now, a young person who's disabled, who's deemed disabled, will qualify for Social Security supplemental income. But as you can see in this slide, it's hardly enough monetarily to sustain, a major lifestyle. So once again, we encourage patients of all ages to stay in the workplace as long as possible. Okay? All right. Now, why does disability get denied? Well, I can tell you, sometimes we have patients apply and never tell us. And so if your doctor's not aware that you're going through the process, that is not a helpful thing, okay? And another thing, too, is that patients who are recently diagnosed, now there are exceptions to this. If a patient is a primary progressive diagnosis and is severely disabled, they may get a Social Security judge to grant immediate disability based upon their physical presentation. That usually does not happen, okay? Now, medical records from providers of all types can be incomplete when it comes to the subject of disability. So getting back to what we talked about earlier, this is why it's important for patients to understand what's in their medical records, because this is what you're not going to read in a neurologist record. Hi, I saw Miss Jones today who's on this MS medication. She's disabled and cannot work. She cannot lift 10 pounds. She cannot sit for an hour. She cannot walk for more than 20 feet. And she can't remember things because she has cognitive disorder. I think she should be totally disabled. Okay, you are not going to find that in medical notes. So it's a process by which the system has to analyze the clinical notes for clues from the provider's notes, as well as what we call objective evidence, which are MRI findings and other reports, okay? And so many patients are surprised to find that if you look in doctors' notes, that they don't make reference a lot of times to disability directly. Okay? And so if they don't make reference to it, how is the Social Security judge, who's a lawyer and a judge, going to know if you're disabled? Okay? So Having copies of your medical records is going to give you a clear picture of what your provider thinks your condition is. Does that make sense, hopefully, to most of you? All right. Now, the primary progressive patient is probably going to have an easier time because of their mobility issues and just because of the presentation, probably by the attorney. Now, lawyers are not mandatory in the process. However, there are companies out there that provide services, and anybody who offers to assist a person going through the process is going to get a fee of approximately $5,000 for doing this. Okay, so understand that there is a price for an attorney, and in more cases than not, they're going to be helpful. All right, so alternative and complementary therapy. Because I'm a chiropractic doctor, I treat a lot of different patients, and over the past 30 years, I was lucky enough to gain experience in multiple sclerosis at a time before there were even medications available. So in my early days of practice, I managed MS patients who were not on any treatments. And I've been able to see the evolution of how alternative therapies, which are now considered complementary therapies, how they've entered the realm of treatment. So what we're talking about are treatments that are not directed at affecting the MS process. So these are not parallel to disease-modifying therapies. So for instance, a person wouldn't go to physical therapy and not take medications if medications were indicated. So think of chiropractic care, massage therapy, aromatherapy, hydrotherapy, animal therapy, music therapy, anything you want to add to your conventional treatment. And these are therapies that you as a consumer, you as a patient, are entitled to. Many patients were surprised to know that they didn't have to be necessarily referred, for a lot of these treatments. Okay. Now, medical marijuana, of course, is a legal issue that has everything to do with the state you're in. And so, we've had patients that when it was legal in Florida, kind of thought that that was the way to go for their treatment. And I can only say that I highly discourage alternative treatments for MS unless your provider is on board with that. Okay. Otherwise, these are used to complement your current treatment regimen. So chiropractic, acupuncture, massage are excellent to accompany your normal neurologic MS care. Okay, so personal advocacy through action. So participating in your medical care means that your provider understands your condition and allows you to make personal decisions. And then participating in events like this is important because, to be honest with you, not a lot of practices have a person like myself that works behind the scenes. And I really enjoy connecting things for patients and making things happen because it's impossible for just a provider to do that. So I can just tell you that patients who are the happiest with any chronic disease are those that stay engaged socially and they stay active. And I know from personal experience, because early in my career, I had a disabled spell for about 2 years where I wasn't practicing. And I know and totally understand how routines and lack of routines happen, where you lose track of days, times, weekends, whatever. And I found that routines are especially important for decreasing the incidence of depression and loneliness and exclusion. So remember that as a patient, you are a consumer, just like when you go to a store, you go to a restaurant, you're to be served as a consumer and you're to be served with respect. And that's exactly what we try to provide for our patients in our center, making sure that you are the person who stays engaged in their health care and plays a role in managing your own care, because without your input, it's almost impossible for a patient to get complete care. So I want to thank everyone, and I'm happy to take any questions if they would like.
All right. Thank you so much, Dr. Chaifetz.
I'm sorry I went over.
That's totally okay. We got a little bit of a late start with the technical problems, so I think we're right about on time. And
Okay.
I appreciate you making time for questions. So, folks, there are a couple of ways that we can handle questions. There is a raise hand feature in the Zoom app. If you touch your screen to bring up the toolbar, you'll see a button that says more with a ... symbol. And that when you click that, it should give you an option to raise your hand. If you do that, I can bring you on the line. Or if you happen to have a question and you know where your mute and unmute button is and you want to take yourself off mute to ask a question right now, please go ahead and do that.
So I do have a question here from somebody. And so here's what the question or statement is. ABC drugs, so we have a person who's very familiar with this landscape. They cost about $1,000 a month when they were introduced. Okay. Mm-hmm. So as each new drug company introduced another drug, they increased. Every other drug raised their price, in effect, spiraling the drug costs. So why do we put all the costs of the insurance on the drug companies? And this patient or a person said they're not a fan of, but the cost has to come out of sight. If the companies don't pay these costs, none of us could afford, and eventually the pricing would take this into account. So here's the thing. I have no problem with insurance companies scrutinizing what they're paying. However, if you're controlling a chronic disease, the cost of it being out of control can spiral much more than the cost of the medication to treat it. So many times these insurance companies have to make a tough decision about coverage. And to be honest with you, I mean, I don't know if we could ever go back to the days to where you literally visit a doctor, you pay them out of your pocket, you go to the pharmacy, you pay for that out of your pocket. Can a person even imagine trying to manage MS on their own personally and financially? So some of the tools we talked about, if you do not have adequate insurance coverage, you definitely have to know how to navigate through the process of foundation funding and what have you.
Okay, other questions, folks? All right. It looks like Pam has a question. Let me unmute you there, Pam. Go ahead.
Thank you. Have you found, Dr. Adam, that with the whole COVID misery that we're all going through, that a lot of your patients kind of are depressed because we're isolating ourselves and maybe getting out of our routines? I feel like I really try to stay in my routine. I've, forced myself to do things every day. And I'm just throwing that out there to, I just put my sunglasses on because it's bright. I'm sitting, I should pull the shade down. But, you got to get up in the morning. You've got to try to walk, exercise, whatever you can do. And, and try to think happy thoughts. And have you found any of this to be true with and none of us can go see a doctor. Doctors' offices aren't open. Of course, we do teleconference with, your doctors.
Well, actually,
at least I don't think San Francisco lady and some of the other people, Raymond in California. Pardon?
Well, we actually.
But I'm just saying, I think that, we've got to do the best of our ability, keep a good mental attitude. That's all.
Yeah. One of the good
I'm done.
One of the good things.
Adam, I can't hear you.
I can hear you, Dr. Chaifetz.
Okay. One of the good things about this whole Zoom thing is patients can still communicate with each other. So, if they have groups that they normally met with, this is one mechanism to do that. But I'm an outdoor person, so even if I get outside and walk around my block or do something outside, I think that this is a time that all of us are going to have to look at what our future is going to be for not only medical care, but just looking at the whole landscape of what our new normal is going to be. So if we look at, the whole in-person thing, it's going to be, I think, slow to get back to where we're going to be able to do the events like we've had them. But I do think that events like this and, conferences like this are important because it does keep people connected with what's happening. I mean, everything that we've gone over today, these are all real life things that are happening. And those that were able to attend today, hopefully give them a little bit of insight as to how they can help themselves in the process. Okay.
All right. We have another question in chat.
Yeah.
Veronica says, can chiropractic care help you with onset of scoliosis due to muscle weakness with MS? What is the best treatment to look for?
Okay, good. Well, that's a great question. So a lot of times, not everything. Okay, so let's back up. When a patient has MS, not everything that they deal with in life is always related to MS. So most likely, if a person has a scoliosis, it may have been there from birth. And so when a patient's diagnosed with MS, a lot of times what happens is other things happen at the same time that may or may not be related to the MS. So in answer to your question, chiropractic care has always traditionally been very effective in the treatment of scoliosis. So if you're interested in seeing what your spine looks like, you may have had a thoracic MRI done already. If you have, your neurologist can tell you if you have scoliosis, and you can also get x-rays done, which will give a chiropractic doctor an idea of what we look for when we treat a patient from a chiropractic standpoint. So believe it or not, MS patients, they can have a high incidence of back and spine pain for a number of reasons, for the simple fact that 4 out of 5 people who don't have MS get back pain.
All right. And Veronica goes on to ask, what are your feelings about virtual physical therapy? Will it help?
Virtual physical therapy is excellent. And we actually have done a virtual physical therapy study that we're doing through our telemedicine research. And we love it because we know that exercise-based therapies are effective. But there are some therapies that are also effective that have to be administered in a hands-on fashion. And those are massage therapies, myofascial therapies, manipulative therapies. These are treatments that chiropractic doctors, physiotherapists, osteopathic doctors, many of us are trained in. So there are a number of things that can be done through a telemedicine format. Like, for instance, if I were a rehab doctor, I've been a director of rehab centers, I could absolutely go on and do and work patients through exercises if I wanted to. But my effectiveness is with my hands, is when I can treat a person hands-on. So your most effective treatment in the chiropractic realm is going to be hands-on, but physical therapy is really, really excellent to do through telemedicine.
All right.
Okay, we have another question here. Okay. Was there an Ocrevus question?
Myrna had asked what you would recommend about having her Ocrevus infusion in June.
Okay, well,
are you comfortable answering that question?
Answer that. Is it in relationship to what's happening in the COVID world, or because without knowing a person's clinical, we don't know if their interval is in June. So
right, let's bring Myrna on the line. Myrna, would you like to discuss this?
Yes, it's just my doubts about taking the next infusion therapy during June with this COVID thing.
Okay.
My neurologist recommends me to wait till August.
Okay, so
I really don't know.
So here's the thing. Great question. Now, understand I'm not your provider, so this is not direct medical treatment advice for you. I can just tell you that this is what we are doing in our center, okay? Our infusion center is infusing patients routinely, okay? We also work with outside infusion centers that have taken a very, very high level of diligence in making sure that the circumstances for patient infusions are done in a manner that's consistent with the guidelines. Now, we understand why a patient would want to delay their infusion, but these are very high-level therapies, which means that if you delay the interval of more than a certain period of time, it could lose its effectiveness, number one. And then in the case of the medicine you're on, you may actually have to go through a retitration period if you're off the drug for longer than maybe 6 months. So it's something you're going to have to discuss with your provider. And then we honestly have had patients on that medication where their infusion centers told them they were not going to do the infusions. So these centers were like oncology cancer centers, and they actually did the opposite. They shut patients out of getting their infusions. So in our case, we have our own infusion center, and then we have off-site partners that we work with, some of them diligently to get our patients in.
Okay.
So I would talk to your provider.
Yeah.
Yes,
And
yes. Thank
Myrna,
you.
as I mentioned, there is more information about that specific topic that was covered in our recent teleconference on COVID-19 and MS. So you can look for that on the Foundation's YouTube page, or look for the audio recording on msfocusradio.org.
Yeah,
Thank
it's
you
always
so
a
much.
provider issue. You definitely want to discuss that with your provider.
All right. Does anyone else have a question? All right. I want to thank everyone for their time and attention. I'm going to go ahead and unmute everyone in case you have any comments that you want to make, but I just want to take a moment before I do to thank you all for being here, for participating, for paying attention, and especially I want to thank Dr. Adam Chaifetz for this vital information on how to successfully advocate for yourselves and your loved ones with MS. Thank you so
all.
much, Dr. Chaifetz.
Thank you all. Have a really wonderful day. And
thank you.
I greatly appreciate this opportunity and would love to do it again. Thank you.
Thank you so much.
Thank you so much.
Bye,
Thank you.
everyone.
Can you repeat besides the foundation, the MS Foundation, can you repeat the other org.org where I can see about the COVID-19?
Yes, the audio recording you should be able to find on our radio station, which is msfocusradio.org. And I will go ahead and put that in the chat.
Thank you.
So everyone can see msfocusradio.org is where you can find it. And if you want to find our YouTube channel, you just search Multiple Sclerosis Foundation.
Perfect.
This presentation from Dr. Chaifetz should be on our YouTube channel within the next 2 weeks. If you want to watch it again or share it with others.
Thank you.
Thank
again.
you. Thank you.
Thank you so much.
Thanks, Casey.
Thank you.
Thank
Bye-bye.
you all.
Yeah, this was great.
Great.
All right.
Thank you, Ms. Casey.
Have a good evening, everyone.
Thank you.
Have a good
Tom.
evening. Good job.
We
Bye.
hope to see you again soon.